Welcome to Quillen College of Medicine, East Tennessee State University. This is the Medical Human Gross Anatomy course. In today's presentation, we will cover the pelvic organs and some clinical correlates that you can take forward into pathology next year and into your clinical years that have to deal with the gross anatomy of the pelvis. So the pelvis can be divided up into two parts, a major pelvis and a minor pelvis. The major pelvis is also known as the false pelvis, and that's the portion of the bony pelvis that's above the pelvic brim or the iliopectineal line. Now the minor pelvis is also known as the true pelvis, and that's the cavity or the portion of the pelvis that's below the pelvic brim and above the pelvic outlet. Now it's important to keep in mind there's some minor differences in shape with the pelvic inlet and the shape of the pelvis in females and males, and obviously that makes sense. Females do something that males don't do if they choose, which is carry a baby for 9 months, and that you can see how the different shape in the female pelvis accommodates that. So in the female pelvis, the pelvic inlet is more oval, and you can see that in the bottom picture of the pelvis here. The pelvic outlet is also larger, so it allows for passage of a baby during delivery, and this is due to the ischial tuberosities being more everted in the female than they are in the male. So this creates a wider and a shallower pelvic cavity. Now in males, the pelvic inlet is more heart-shaped, which you can see kind of looks like Mickey Mouse ears in the top image on the left, and the pelvic outlet is smaller because those ischial tuberosities are not everted. And this gives a narrower and a deeper pelvic cavity. Now moving on to some male pelvic organs, we'll cover some male pelvic organs, and then we'll cover some female pelvic organs, and then move on to a few organs that are in both males and females as we progress through the presentation. So we'll take the prostate first, and obviously this is in males. The prostate is located at the base of the bladder, and it can be divided up into 6 lobes. There's an anterior lobe, a posterior lobe, a middle lobe, and then right and left lateral lobes. Sorry, I said 6 lobes, it's actually 5 lobes. So there's an anterior lobe, a posterior lobe, a middle lobe, then a right lateral lobe, and a left lateral lobe. So the anterior lobe of the prostate is in front of the urethra, which you can see in the image here. The posterior lobe is behind the urethra. Now the middle lobe of the prostate is between the urethra and the ejaculatory ducts. So you can see in a sagittal section there's an anterior lobe, a posterior lobe, and then a medial lobe. And then if you take the section and you look at it in an AP dimension, then there's obviously on both sides of that a right lateral lobe and a left lateral lobe. Now this is important when urologists go in and do prostate biopsies. They will take core biopsies of each lobe. So there are typically there's at least 2 biopsies done, if not more, of each of these lobes, and as well as a transitional lobe, which standard of care now is at least 12 biopsies in a prostate biopsy specimen. Now these lobes are important clinically, and we'll see in the next slide with BPH versus prostate cancer and nodular prostates on rectal exams. Given the location of the rectum just posterior to the prostate, you'll learn in your clinical years how to do a rectal exam, and you can actually palpate portions of the prostate on a digital rectal exam because of the anatomic location of the prostate just anterior to the rectum. So you may be able to feel nodules or irregularities in the prostate on a digital rectal exam. Now the ducts of the prostate open into the prostatic sinus, and this is on both sides of the prostatic crest, on the urethral crest. So the ducts open on both sides of the urethral crest, and there's a little elevation which is the urethral crest, or also called the vera montana, which you can see the ducts just adjacent to both sides of that. The prostate also secretes PSA, so that's one screening tool, although some say not very good, for prostate cancer. Obviously with prostate cancer, the PSA is usually elevated, although I've seen biopsies with a PSA well within normal limits and the patient has prostate cancer. I've also seen prostate biopsies where the PSA has been through the roof and there was no prostate cancer detected in the biopsy specimen. Doesn't mean there was no prostate cancer there, it just means there was no prostate cancer biopsy with PSAs through the roof. So now clinically, the two most common things in the prostate are BPH, or benign prostatic hypertrophy, and prostate cancer. Prostate cancer usually occurs at the periphery of the prostate gland. So this is one of the reasons you may be able to palpate it on a digital rectal exam. And also, again, I told you about the PSA, but then also a digital rectal exam is used for screening. Now, BPH usually occurs in middle-aged to elderly males. This occurs in the periurethral region. And so because of that, males, particularly older males, will get symptoms that they won't be able to void their bladder completely, or they may get frequency of urination. And all of this goes with you've seen the commercials probably for BPH where the old guy gets up in the middle of the night, can't sleep through the night without having to wake up and go to the restroom. And that's a common symptom of BPH. And that's because of the periurethral region. So it actually occurs in the periurethral region and can constrict a little bit on the urethra, and that allows difficulty or produces difficulty in voiding. Also keep in mind that this is not a pre-malignant condition and does not predispose to prostate cancer at all. Moving on to the epididymis. The epididymis consists of a head, a body, and a tail, and this is where the maturation and storage of sperm takes place. So this sits on the posterior and superior aspect of the testicle, and you can see it here. It just looks like a worm sitting on the testicle basically, and then there's a head, a body, and a tail. The tail of the epididymis leads into the vas deferens, and so the vas deferens allows for the movement of sperm, which is produced in the testicle, stored and matured in the epididymis, and then will travel through the vas deferens to get to the ejaculatory duct. Now, the vas deferens will enter the pelvis at the deep inguinal ring, and it's important to keep in mind that this enters just lateral to the inferior epigastric arteries. And then also we will see again as this courses over the urinary bladder and then posterior to the urinary bladder, it will course superior to the ureter at the location of the urinary bladder. Now the seminal vesicles, also seen in males, these are just inferior and lateral to the vas deferens on the posterior aspect of the urinary bladder, and then the union of the seminal vesicles with the vas deferens and the seminal vesicles will come together on the posterior surface of the urinary bladder and form the ejaculatory duct. So that's just, the ejaculatory duct is just the union of the vas deferens and the seminal vesicle, and then the ejaculatory duct opens into the prostatic urethra in the region of the urethral crest of the vira montanum. Now here we see the posterior view of the urinary bladder with the prostate, and you can see the ureter coming down, and then just passing superior to the ureter on the posterior surface of the bladder is the vas deferens. Then you can also see the seminal vesicles, which will join with the vas deferens to form the ejaculatory duct. And moving on to the testicles, you'll remember from embryology that the testicles develop retroperitoneally and then descend into the scrotum. Testicles also produce sperm and secrete certain hormones, which you'll learn all about in biochemistry and physiology and other courses. So the testicle is supplied by the testicular artery and it's drained by the pampiniform plexus of veins. And keep that in mind, the testicular artery we saw originating in the aorta up in the abdomen. Lymphatic drainage from the testicles goes to the lumbar and aortic nodes. So that's important. So if there's a testicular malignancy, the urologist doing the surgery is not looking in the inguinal region, which some people may think, well, the testicles are pretty close to the inguinal region, so let's look at the inguinal nodes. Well, due to the lymphatic drainage to the lumbar and aortic nodes, looking at the inguinal nodes will do no good. So frequently in surgeries with testicular cancers, to see if there is metastasis, the urologist goes and gets the lumbar and aortic nodes to look for metastasis. Now also the first thing you'll see when you cut into the scrotum and expose the testes is a white, thick connective tissue covering, and that's just known as the tunica albuginea. Now, from a clinical perspective, there's testicular torsion, and there's also epididymitis or orchitis, and I'll give you some ideas about that. They're both going to present with testicular pain, so if somebody comes into the ER or your clinic with testicular pain, the two big things on your differential is epididymitis or orchitis and testicular torsion. Obviously, they're treated separately, and one is a urologic emergency because the testicle can infarct with testicular torsion, and then the patient could lose a testicle. So starting with epididymitis or orchitis, this is just inflammation of the epididymitis, of the epididymis, or of the testicle. Again, it presents with pain. The first thing you'll do after a quick physical exam will be ultrasound. You'll order an ultrasound for the testicle. Now, it's important in reading or looking at testicular ultrasounds to know which side is which and which side has the pain. So in this example, I'll tell you that A, or the figure on the left, is the testicle without the pain, and that B, or the figure on the right, is the testicle with the pain. So you see the color Doppler, which shows blood flow, and it's not important for you to realize red and blue right now and the flow of the blood, but it's important to see that the image on the right, or the testicle in B, has increased blood flow. So with epididymitis, orchitis, with an infection of the testicle, there will be increased blood flow. So with pain in that side and increased blood flow, then the diagnosis will be epididymitis or orchitis, treated with antibiotics, no surgery needed. Now, similar to that, with testicular torsion, a patient will present with testicular pain. However, in the ultrasound that you order, again, it's important to know which side has the pain and which side doesn't, because there can be varying blood flows in different patients' testicles. So, but however, there should be similar blood flows between the left testicle and the right testicle. So in this, you can see the image RT at the bottom will identify the right testicle, and LT on the right side of the image identifies the left testicle. So this patient actually comes in with right-sided testicular pain. So you look at the right and you see no blood flow on that right testicle, and you see blood flow on the left testicle. So absence of blood flow is testicular torsion. Call the urologist, urologic surgery. They'll go in there and try to salvage the testicle with a surgical operation. It's also important to keep in mind clinically cryptorchidism. You heard about this in embryology with the descent of the testes. So failure of the testes to descend is known as cryptorchidism. 80% of these will descend by 1 year, however the other 20% don't, and it's important for the pediatric surgeon or the pediatric urologist to go in and pull that testicle down, and then they'll tack it down into the location where it should be. Cryptorchidism is associated with decreased fertility, and it's associated with an increased risk of certain germ cell tumors, certain testicular tumors. And not only is it associated with certain germ cell tumors in the testes that has not descended, but also in the contralateral testes. So if one testes has not descended, there's also an increased risk of tumors in that testicle, but also the opposite testicle. All right, moving on to some pelvic organs. Now we will see some of the female pelvis. So the female pelvis, now many of you in the females, a lot of the female cadavers will have had hysterectomy, so you won't be able to identify some of these organs. So it is important that if you're one of the cadavers that does have a female and that has not had a hysterectomy, it's important to identify all these and share with your colleagues and your classmates. So there's some ligaments made up that are extending to the lateral, from the lateral uterus to the pelvic wall, and the encompassing ligament is called the broad ligament of the uterus, and this is just 2 layers of peritoneum, again, which extend from the lateral margin of the uterus to the lateral pelvic wall. It helps to hold the uterus in position. It will contain the fallopian tubes, the uterine artery, uterine vein, round ligament of the uterus, and ovarian ligament, which we will see. It does not contain the ovary, which we'll also see again, but it does attach to the ovary in the region known as the mesovarium. And we'll go through the mesovarium, mesosalpinx, and mesometrium in just a minute. The ovarian ligament is a fibromuscular cord which is within the broad ligament and extends from the ovary to the uterus below the fallopian tube. The suspensory ligament of the ovary is important, and you will be able to see that in your cadaver if they have not had a hysterectomy. And this is just the peritoneum that's extending from the ovary to the pelvic wall, and it's important because it contains the ovarian vessels. Now the cardinal ligament, which is also known as the lateral ligament of the uterus, is the portion of the broad ligament, or the portion of the connective tissue that's extending laterally from the cervix and the vagina to the pelvic wall, and it supports the uterus. And so this is lower down the uterus where the cervix and the vagina is. So here in this image you can see the broad ligament, which is just sort of draped over all of the structures, the round ligament, the fallopian tube, and given where they're located, that broad ligament can then be divided up into the mesovarium, the mesosalpinx, and the mesometrium. So the mesovarium is the peritoneal fold that's connecting the anterior surface of the ovary with the posterior layer of the broad ligament. So again, this is not covering the entire ovary, but just a portion of it. The mesosalpinx is the portion of the broad ligament that suspends the fallopian tube, and then the mesometrium is below the mesosalpinx and the mesovarium. So now keep in mind the round ligament will course anterior and below the fallopian tube with the broad ligament, and the round ligament will enter the deep inguinal ring, it will exit through the superficial ring, and it will attach to the labia majora. Now moving on to the ovaries, so the ovaries lie on the posterior aspect of the broad ligament, and then anatomically the ovaries are also bound with a relationship in between the external and internal iliac vessels. Now there's no peritoneal covering over the pelvic organs, and this is important because if there's an ovarian cancer, a lot of times females will present with ascites or fluid in their abdomen, fluid in their belly. That sometimes will be the first presentation of an ovarian cancer. Well, because there's no peritoneal covering over the ovaries, these cancer cells can shed in the abdominal cavity. So it's real easy to insert a needle into the abdominal cavity, get some of that fluid out of there. Pathologists can look at the fluid under a microscope and oftentimes see the malignant cells that have been shed into the peritoneal cavity or shed into the abdomen in that fluid, and can get a diagnosis fairly non-invasively. The ovaries are supplied by the ovarian arteries, and again, this courses in the suspensory ligament. It's important to remember that the ovarian arteries will anastomose with the uterine artery, and we'll see that later. And then keep in mind, which we saw earlier in the course, the right ovarian vein will empty into the inferior vena cava, and the left ovarian vein empties into the left renal vein. And then here's just a picture showing the ovarian artery coming from the abdominal aorta. And again, you've seen this already, but it crosses external to the iliacs, iliac arteries and iliac veins, enters the pelvis, then it will course in the suspensory ligament and anastomose with the uterine artery and its branches. And here's just an image showing where the ovarian artery will be coursing to supply the ovary, and then will anastomose with the uterine artery. Moving on to the fallopian tubes. The fallopian tube, there's two of them bilaterally, and it communicates the uterus with the peritoneal cavity. There's a couple of portions of the fallopian tube which is important for you to keep in mind. There's the uterine part, which is basically the origination of the fallopian tube from the uterus. There's the isthmus, and then the isthmus leads into the ampulla, which is the longest and widest portion of the fallopian tube, and then the ampulla leads into the infundibulum, which is the funnel-shaped ending of the fallopian tube, which actually ends into the fimbriae, which is the finger-like projections of the fallopian tube, which you'll be able to see in your cadaver if you have a female cadaver with their organs. Also, usually fertilization occurs, you heard this in embryology, but it usually occurs in the fallopian tube in the region of the infundibulum or the ampulla. Moving on to the uterus now. In a female, normally the uterus is anteverted and anteflex, so it's tilted forward and it's also flexed a little bit, so it's not straight. It rests on the posterior superior aspect of the bladder. And again, there's a couple portions of the uterus to keep in mind. There's the rounded superior aspect of the uterus, which is known as the fundus. Then there's the body, which leads to the isthmus. The body is the main portion of the uterus, which is below the fundus and above the isthmus. And then the isthmus is the constricted part of the uterus, which is between the body of the uterus and the cervix. And the cervix is the inferior narrow part of the uterus, and the cervix actually projects into the vagina. And that's when you do a pap smear, or if you're female you've had a pap smear, that's what the pap smear is for. The pap smear is to scrape the cells off of the cervix to look at those and make sure they're not dysplastic, precancerous, or cancerous. The cervix has an internal os and an external os. The internal os is the junction of the cervical canal within the uterine body, and the external os is the opening of the cervical canal into the vagina. And actually this transition zone between the cervix is where you will want to scrape between the cervix. On the external os will have a transition zone, which you'll see in histology next semester. That's where there's a change of histology and change of epithelial lining, and that's where you want to scrape. You'll get some squamous cells and some glandular cells as well, and that's where usually when there's dysplasia or precancerous changes, that's usually where it occurs. Now clinically, you've all heard about fibroids of the uterus. These are called leiomyomas. They're just smooth muscle tumors that are benign. You can have leiomyosarcomas, which are cancerous. Those are much less common than the benign fibroids or leiomyomas, usually in the middle to late reproductive years, and they can be anywhere from asymptomatic to producing severe pelvic pain. And you can see there's different types. There's subserosal, intramural, and submucosal, which you don't need to worry about, but you can see an image of a uterus in the bottom right that has been cut open, and you see all these little balls, and those are just smooth muscle tumors. There's also uterine prolapse, which you'll probably see when you start to get in your clinical years, especially on OB, and this is due to a weakness of the pelvic diaphragm and the musculature of the pelvic diaphragm, and the uterine just prolapses or drops, frequently due to multiple childbirths or increased abdominal pressure over long periods of time, and that just causes weakness of the pelvic diaphragm, which is holding and supporting the uterus, and that uterus will just drop down lower and can produce symptoms, and then an OB or a urogynecologist will go in there and have to resuspend the uterus sometimes. Moving on to the vagina. So the vagina is where the cervix projects into, and there are a couple of portions of the vagina. It's important to keep in mind the fornix, which is the recess between the cervix and the vaginal wall. Now the vagina is supplied by the vaginal branches, or the vaginal branches of the uterine artery, as well as the internal iliac arteries. Keep in mind with the vagina, the lymphatic drainage, this is important. The upper 3/4 drain to the internal iliac nodes, and the lower 1/4 drains to the superficial inguinal nodes. So if there's cancer in a portion of the vagina, it's important to know, is it the upper 3/4 or is it the lower 1/4, because that's where the surgeon will go dissect out the nodes and remove the nodes to look for metastasis. And obviously, if it's in the lower 1/4, then it's the superficial inguinal nodes. If it's in the upper 3/4, they'll dissect out the internal iliac nodes. So moving on to other organs in the pelvis, which both male and females have. So the ureter, we've seen this already in the abdominal lecture. The ureter descends retroperitoneally on the anterior surface of the psoas. It crosses the pelvic brim anterior to the common iliacs. It's usually accompanied by the uterine artery in females, and it inserts posterior and inferior to the vas deferens on the posterior lateral aspect of the bladder. Now, the relation of the uterine artery with the ureter is important to keep in mind, and the saying which you may have heard is water under the bridge. So the ureter is carrying urine, it's carrying water, so water under the bridge. So the ureter is actually coursing below the uterine artery, or the uterine artery is above and anterior to the ureter. And that's important to keep in mind. Obviously, if you're doing surgery in this region, if you're a gynecologist operating, doing a hysterectomy, you don't want to clamp the ureter, you'd rather clamp the uterine artery. And here's an image of the urinary bladder. So we have the urinary bladder as well, which you'll see today, and there's an apex, which is the top portion, the superior portion of the urinary bladder. Then there's a fundus and a base, and I encourage you to open up the urinary bladder, and you'll be able to see a region, the trigone, and you'll be able to appreciate the muscle. The urinary bladder is all muscle, and there's a triangular region called the trigone, which is easy to identify because all you have to do is identify the ureteral orifices and the urethral orifice. If you connect all those, it makes a triangular region of the urinary bladder, which you can see on the inside. And here's an image of the posterior aspect of the urinary bladder. You've seen similar ones already, but again, this is just showing you how the ureters are coming down and implanting on the posterior superior aspect of the urinary bladder, and you can now appreciate again how the vas deferens is coursing superior to the ureter, closest to the urinary bladder, and then how the vas deferens and the seminal vesicles join to form the ejaculatory duct. Moving on to the rectum, another organ, if you will, in the pelvis. The rectum is just the continuation extending from the sigmoid colon to the anal canal. It follows the curvature of the sacrum. And there's the ampulla, which is the lower dilated part of the rectum above the pelvic brim, and this is where feces is stored. There's a couple of foldings of muscle layer that are transverse folds, which help to support the feces, and these are called the valves of Houston, or some people say valves of Houston. And these are just the 3 transverse folds of muscle which help to support the feces. Moving on to the blood supply of the rectum, there's 3 major blood supplies. This is from the superior, middle, and inferior rectal arteries. The superior and inferior rectal arteries actually anastomose with each other, so it's important to keep that in mind. The superior rectal artery is a continuation of the inferior mesenteric artery, so that's pretty simple to find. The middle rectal artery we will see when we cover the vascular supply in a few minutes, but the middle rectal artery originates from the internal iliac artery, and then the inferior rectal artery originates from the pudendal artery, which we'll see later down in the pelvis. And again, the superior rectal artery and the inferior rectal artery will form an important anastomosis. Superior rectal vein, keep in mind here also, this is important clinically. The superior rectal vein drains into the portal system, and the middle and inferior rectal veins drain into the cable system. So that's important for metastasis, as to where a metastasis could go, if there's hematogenous spread, or if there's spread through the blood system instead of lymphatics through the vascular system. So venous spread, obviously if it's a region supplied by the superior rectal vein, will go to the portal system, and venous spread, if it's a region supplied by the middle or inferior rectal vein, will enter into the IVC or the cable system. Now here's an image showing you the middle rectal artery and its origination off of the internal iliac, and also the middle rectal artery will supply the posterior aspect of the rectum. Now the anal canal extends from below the pelvic diaphragm to the anus. There's 5 to 10 longitudinal folds in the upper half of the anal canal, and you can see these folds in this picture here, and these folds are just called anal columns. There's also some mucosal folds which connect the lower end of the anal columns, and these are called anal valves. Not true valves, but mucosal folds, but these are termed anal valves. Now, there's an internal anal sphincter and an external anal sphincter. The internal anal sphincter is the thickening of circular smooth muscle in the lower part of the rectum, and then the external anal sphincter is formed by skeletal muscle and is actually under voluntary control. Now, there's something that's very important called the pectinate line or the dentate line, and this is just the serrated line that's following the anal valves, and this separates above this line and below this line separates a couple of things that are important clinically. So the venous drainage above the line drains through the superior rectal vein to the portal system, and the venous drainage below the line is from the middle and inferior rectal vein to the cable system. Now also lymphatic drainage is also delineated by this pectinate line, and the lymphatic drainage above goes to the internal iliac nodes, and then lymphatic drainage below goes to the superficial inguinal nodes. So depending on where possibly a malignancy or something's going on, it's important to keep this line in mind. Now, you've all heard about hemorrhoids, and hemorrhoids are just congested, dilated arteriovenous channels, and this pectinate line helps to delineate or define what is an internal versus an external hemorrhoid. The hemorrhoids usually present with rectal bleeding. There can be pain, and I'll tell you here in just a second which ones have pain and which ones don't. Different treatments for it. If they're not too bad, you can just do a high-fiber diet, because usually these are produced by increased intra-abdominal pressure, constipation, things like that. You can do banding, so the surgeon will just go in and stick basically a rubber band, clamp it off, the blood supply is infarcted, and they just infarct off, or you can have actual surgical excision or surgical removal of hemorrhoids. So internal hemorrhoids are above this pectinate line that we just talked about, and they're painless. So these people often present with painless rectal bleeding. Now the external hemorrhoids are below the pectineal line, and these are painful. So again, that pectineal line is important in differentiating internal from external hemorrhoids. Now, all these organs in the pelvis create some pouches which are important clinically, so there's a couple of pouches we need to go over. Obviously, if you're a male or a female, the pouches are a little different because you do or you don't have a uterus, so that creates different pouch. So in a female, there's a rectouterine pouch, which is also known as the pouch of Douglas, and you heard about this initially in embryology. And this is just, the rectouterine pouch is just the recess which is formed by the peritoneum between the rectum and the uterus. So again, this is a female, posteriorly, but between the rectum and the uterus is called the rectouterine pouch, also known as the pouch of Douglas. It's behind the posterior fornix of the vagina, and this is the lowest portion of the peritoneal cavity. So frequently blood, fluid, ectopic pregnancy, if it's not in the fallopian tube, this is the common place for that to occur. Now there's a vesicouterine pouch, again in a female, and this is the recess between the bladder and the uterus. So it makes sense. Rectouterine pouch between the rectum and the uterus, vesicouterine pouch between the bladder and the uterus. In males, there's a rectovesical pouch because there is no uterus, so this is the recess between the bladder and the rectum in males. Coldocentesis, not done very often anymore, but because the rectouterine pouch or the pouch of Douglas sits between the rectum and the uterus, and it's the lowest portion, if a female of childbearing age would come in. This is before we had ultrasound or anything like that, and possibly pregnant or possibly signs of an ectopic pregnancy. One of the things they could do is what was called a colocentesis. So they would go through the rectum and insert a needle into that pouch of Douglas and withdraw any fluid that was there. And so they could analyze the fluid. If there was blood in the fluid that collected in that pouch of Douglas, then there was concern of a possible ectopic pregnancy, a ruptured ectopic pregnancy with the blood there. Likewise, if there was anything else going on, they could withdraw the fluid and analyze it microscopically. Nowadays, with different imaging modalities, you probably won't see one of those given CT scans if the patient's not pregnant, given ultrasounds, if it is a fertile female. So, but that's important to keep in mind because of the anatomy. Again, because that rectovesical pouch or the pouch of Douglas is the lowest portion of the pelvis, of the peritoneal of the pelvis, and that's the most dependent portion because it is the lowest, so that's where any fluid will accumulate. Okay, moving on to the blood supply of the pelvis. Here's an image showing a number of the vascular structures. You won't see all of these vascular structures when you get in and do the dissection, but you will be able to see many of these. So all of this originates from the internal iliac artery. So the internal iliac artery can be divided into two divisions. There's a posterior division and an anterior division, and we'll go over the posterior division first because to me this is the easiest. So there's three arteries that arise from the posterior division of the internal iliac. These are the iliolumbar, the lateral sacral, and the superior gluteal artery. So the iliolumbar artery will arise from the internal iliac and course superior laterally and deep to the psoas muscle. The iliolumbar artery will supply the iliacus and the psoas and the quadratus lumborum. Now in the same region, there's the lateral sacral artery, which arises in the same region of the iliolumbar artery. However, the lateral sacral courses medially and anteriorly and inferiorly to the sacral plexus. And you can see in this image here, this is number 3. So number 3 is identifying the posterior division with the iliolumbar coursing superiorly and the lateral sacral coursing down and inferiorly along the sacrum. Now the last branch of the posterior division is the superior gluteal artery, and this is pretty simple to identify in the lab because it courses between the lumbosacral trunk and S1. You also see later on when we get to the gluteal region that the superior gluteal artery continues to course and enters the gluteal region above the piriformis to supply some muscles in the gluteal region. So those are the three branches of the posterior division of the internal iliac: the iliolumbar, the lateral sacral, and the superior gluteal. Those three are pretty straightforward and pretty simple. Now the anterior division gets a little more difficult to identify all of these, especially in lab. The inferior gluteal artery is pretty simple to identify. So just like the superior gluteal artery courses between the lumbosacral trunk and S1, the inferior gluteal artery usually courses between S2 and S3. So you can see that with the sacral plexus and S2, S3 deep in the pelvis. Occasionally it will skip one or two and it may course between S3 and S4. So keep that in mind. Not very common, but it may happen. So the superior gluteal artery of the posterior division courses between lumbosacral trunk and S1, and then usually the inferior gluteal artery, which arises off the anterior division, will course between S2 and S3. The inferior gluteal artery will also leave the pelvis through the greater sciatic foramen and go into the gluteal region, which we'll see as well to supply some of the gluteal region, and it will enter the gluteal region below the piriformis artery, and that's where it gets its name, inferior gluteal artery. It's inferior to the piriformis, which you'll see later in the gluteal region. The internal pudendal artery, which is identified as number 8 in this image, leaves the pelvis through the greater sciatic foramen between the piriformis and the coccygeus muscle. It'll enter the perineum through the lesser sciatic foramen, and we'll see it again when we cover the perineum later on. The umbilical artery will course lateral to the bladder. It it will give rise to some of the superior vesical arteries. But the important thing about the umbilical artery is it courses and it goes out to the abdominal wall, and the distal part of the umbilical artery becomes obliterated and is known as the medial umbilical ligament. So the easy thing to identify about this is the artery that becomes obliterated, and it actually courses and attaches to the anterior abdominal wall out anteriorly. Now, I mentioned the superior vesical arteries arise from this. It's very difficult to identify the superior, middle, and inferior vesical arteries. So basically, the vesicular arteries supplying the urinary bladder, if they're, just look at them, if they're supplying the superior aspect of the bladder, they're superior vesical arteries. So they're named where they're going. If they're supplying the inferior aspect of the bladder, they're inferior vesical arteries. And if they're supplying the middle aspect of the bladder, they're middle vesical arteries. So don't worry too much about where the vesical arteries are arising from. Just worry about where they're actually supplying, and then name them superior, middle, or inferior. The obturator artery is the next artery, and this is identified as 5 here in this image. And this goes through the obturator foramen, and it supplies the thigh muscles and the hip joint, which we'll see in the lower extremity later on. Moving on to the middle rectal artery, which is identified as number 7 in this image. Again, you've heard me talk about the middle rectal artery when we did the rectum, but this courses medially to supply the lower part and the posterior aspect of the rectum. And then finally, there's the uterine artery, which arises off the anterior division. And we've seen that and heard about that already with the uterus, but this courses medially in the base of the broad ligament to the lower uterus and cervix. Again, it's anterior and above the ureter, and at anastomosis with the ovarian artery. And just keep in mind that the vaginal artery arises from the uterine or internal iliac artery to supply the vagina. So here's an image showing you basically what we just covered. So you can follow down the internal iliac artery and then locate the origins of the 3 branches of the anterior division of the iliac artery. So you can see the iliolumbar, which is coursing up superiorly, and you can also identify the lateral sacral, which is coursing down inferiorly on the aspect of the sacrum, and you can see that labeled here. And then also the last branch of the anterior division is the superior gluteal artery, which is pretty easy to identify because you can see it coursing between the lumbosacral trunk and S1. Then you move on to the posterior division, and the easiest vessel to identify in the posterior division will be the inferior gluteal artery, which you see labeled here. And remember, it usually courses between S2 and S3, so you can easily find the lumbosacral trunk, S1, S2, S3. And then when you identify those, the one coursing usually between S2 and S3 is the inferior gluteal artery. And then coursing down inferiorly also, usually in the same region as the inferior gluteal artery, you can see the internal pudendal artery. So this will help you when you get in there to dissect today, help you be able to identify the majority of these vessels that are in the pelvis. Okay, moving on to a few more arteries down here. This image is kind of an oblique image, but it will help you be able to see and identify the medial sacral artery, which is just a single unpaired artery. It arises from the posterior aspect of the aorta, just above its bifurcation. So go up to the aorta where it bifurcates into the iliacs, and on the posterior aspect, there's going to be an artery running down inferiorly midline that descends anterior to the sacrum, and that's the medial sacral artery, and this supplies the rectum, again, which you've heard about. Keep in mind also talking about the rectal arteries, the superior and inferior rectal arteries, which are anastomosing. And then finally, here is just an image of an arteriogram, which can identify some of these, many of these pelvic arteries that we just talked about. So hopefully this wasn't too confusing and this was clear for you. If you have any questions, again, don't hesitate to contact me or email me at denim@etsu.edu.